Hi all, welcome back. Today we are going to discuss about another important case in the emergency department in continuation with our case-based discussions of emergency conditions. It's going to be anaphylaxis. First, I will be giving you a case scenario in which you will interpret and then we will discuss how to manage the case of anaphylaxis. I am Dr. S. Prakash Babu, MD Emergency Medicine, Associate Professor, Department of Emergency Medicine, KIMS and RC, Changalpattu. So let's look at the case. Here you have a 30-year-old woman was brought to the emergency department after having a sudden onset of breathlessness and wheezing. She had sore throat since 2 days, for which her family doctor has prescribed an amoxicillin course. And she had taken the tablet some 2 hours back and was brought to the emergency. On presentation, her airway was maintainable with a respiratory rate of 30 and a saturation of 82% on room air, and her pulse rate was 140 beats per minute, and her BP was on the lower side with 70 by 40 millimeters of mercury. When you examine the patient is obtended with reduced GCS. There is perioral cyanosis, swelling of the lips and tongue. There is stridor, which is audible, also wheezing. The patient had labored breathing. Her skin is cool and the extremities were clammy with large arterial lesions all over the body. So, what do you think is the diagnosis in this case? So, the catch points here are a female patient with an intake of an antibiotic and presented with mainly the swelling of lips, stridor and wheezing, and arterial lesions, along with a reduction in BP saturation and high respiratory and pulse rate. So exactly, you guessed it right. It's a case of an allergic reaction. A more serious form of allergic reaction is the anaphylaxis. So how are you going to approach this patient? What is the drug of choice? And what are the differentials you need to consider when you are going to manage the patient? So first of all, coming to the approach, you know, any patient presenting to emergency, you take chief complaints, the patient, and then you proceed with an initial assessment. You stabilize the patient before confirming the diagnosis, and then you take a sample history, then you go on to investigations, and then you come to your final diagnosis. So this is the approach. Once final diagnosis is made, you will treat the patient definitively and dispose from the emergency room. So coming back to the current case, the chief complaints of the patient were of sudden breathlessness after seemingly taking a beta-lactam antibiotic. The patient has taken amoxicillin. Allergy and anaphylaxis are the most common causes of sudden onset of breathlessness, especially after consumption of a drug. More so when the patient has taken antibiotics, that is beta-lactam. Beta-lactam antibiotics are the most frequent drug-related causes of anaphylaxis. So the correct patient is undergoing an anaphylactic reaction. There is tongue swelling and arterial rash all over the body, which support the diagnosis of anaphylaxis. So, what are the points you need to check in the initial assessment? In any patient presenting to emergency, in the initial assessment, you mainly concentrate on airway, breathing, and circulation and their stabilization, along with stabilization of the neurological system. Initial assessment and stabilization of the patient undergoing anaphylaxis is a bit modified. Rather than ABC, you go with AEBC, where E stands for epinephrine. That's right. The patient is having a maintainable airway at the time of presentation, but the scenario also shows that the patient is also having swelling of tongue and the lips, angioedema. Angioedema is a very, very serious disorder. It can progress very fast to complete airway obstruction. So, airway maintenance takes precedence over anything else in the current patient. So how are you going to manage the airway in a patient, especially having lip swelling and tongue swelling, which makes the airway a difficult airway? Airway in patients is deemed to be difficult, especially in the presence of angioedema. An experienced practitioner and a difficult airway caught with specific plan of action has to be present before giving a paralytic. If you are not confident of giving a paralytic, you can either try for awake intubation with a video laryngoscopy. Be prepared to secure a surgical airway if necessary. If even if an experienced provider is not able to secure the airway, you can use retrograde intubation also, wherein you go in surgical, you insert a stylet into the trachea and then you pass the tube from behind to make it a oropharyngeal intubation. Because you cannot hold the cricopharyngeal area for longer duration, you go for retrograde intubation. Use short-acting drugs like succinylcholine for paralysis. As far as possible, avoid paralyzing these patients. So once you have managed the airway, the next step is epinephrine. This is the drug of choice for anaphylaxis. A dose of 0.3 to 0.5 milligrams in an adult patient. In the given scenario, the patient is 30 years old, so you can give 0.3 to 0.5 milligrams intramuscularly. Earlier, it used to say subcutaneous route is the option, but subcutaneous route, as the patient's circulation is compromised, cutaneous blood flow is the first one which gets compromised. So you cannot afford to waste the drug by giving subcutaneous and wait for the patient to sink. Rather than that, giving intramuscular injection has better effectiveness. Severe case with circulatory compromise can receive intravenous infusion if you have experience in giving intravenous infusion. Be careful while giving intravenous infusion of epinephrine because there will be severe vasospasm. You will be needing a central line access for giving epinephrine. You cannot give it through peripheral infusion, and patient can have gangrene of his limbs. So once epinephrine has been given, you need to take care of the breathing. The current patient is having a compromised breathing with a labored breathing with a respiratory rate of 30 and a saturation of 82%, which indicates her breathing is compromised. Support breathing with 100% oxygen, and as you have secured a definitive airway already, either a surgical airway or a oropharyngeal intubation, you continue with mechanical ventilation, adjust the settings to maintain a saturation of 90 to 94%. Presence of cyanosis indicates presence of high concentrations of deoxygenated hemoglobin in the blood, which indicates either a problem with the respiratory system or a problem with the circulatory system in the form of shock. So circulation in the given patient, pulse rate was 140 beats per minute and BP of 70 over 40 millimeters of mercury with peripheral cyanosis, which indicates there is a circulatory shock. You need to give, along with epinephrine, IV fluids, especially crystalloids, 20 ml per kg bolus to maintain a minimum systolic BP of 90 millimeters of mercury. You can repeat 20 ml per kg thrice in an adult patient within the first hour and start varilopessars early in case the shock is not improved. Epinephrine IV infusion is the drug of choice for shock. You can also use norepinephrine if you are not experienced with giving intravenous epinephrine. Closely monitor the patient. So once you stabilized, given epinephrine, your ABC are stabilized and the patient is stable, you go for sample history. The classic presentation of anaphylaxis usually begins with pruritus, especially after consumption of a food, an allergen, exposure to an allergen, or consumption of drug. Starts with pruritus, followed by cutaneous flushing, and then there will be urticarial rashes. It will be followed by a sense of fullness in the throat, especially when there is an angioedema developing. Patient will be anxious. There will be a sensation of chest tightness, shortness of breath, and lightheadedness. A lump in the throat or hoarseness of voice indicate life-threatening laryngeal edema. You need to be very, very fast in securing your airway. Associated symptoms include abdominal pain along with cramping, nausea and vomiting with diarrhea, bronchospasm, rhinorrhea, conjunctivitis, and hypotension. It can progress very rapidly to respiratory distress, decrease levels of consciousness and circulatory collapse, and finally can culminate in cardiopulmonary arrest and can lead to death if not attended appropriately. The signs and symptoms begin usually within 60 minutes of exposure. You should ask the patient about previous similar episodes or minor allergic manifestations, especially when presented with some checks. Drug history must take a complete drug history, as I have explained in the sample history taking of an emergency patient. Ask about recent drugs taken, history of exposure to any known allergens. Most of the patients will have known their allergens, especially foods like peanuts. So let's look at what are the common causes of anaphylaxis. The list is very extensive and I cannot tell you everything here. Conveniently, I have divided them into drugs, foods and additives, and allergens. Drugs, especially beta-lactam antibiotics, as in the current patient, acetylsalicylic acid, trimethoprim sulfamethoxazole, vancomycin, NSAIDs, and virtually any drug can lead to anaphylaxis, but these are the common drugs. Foods and additives, especially shellfish, soya beans, nuts, as I told, peanuts or tree nuts, wheat, milk, eggs, salicylates, seeds, and sulfites. Foods containing sulfites, especially those roasted on foods, will contain sulfite and they can lead to anaphylactic reactions. Allergens, especially Hymenoptera stings, honeybee stings, you would have seen plenty of cases of anaphylaxis for Hymenoptera stings. Insect parts, molds, radiographic contrast material. This is one of the most common presentations to ED. Patient comes to OPD, gets shifted to radiology for an investigation. The radiologist injects the contrast agent and then suddenly patient collapse. The patient is shifted to emergency. When you look at the patient is undergoing anaphylaxis. One important point to remember: when a patient has presented with radiographic contrast material, patient may not have any signs of urticaria or pruritus or any rash on the body. Patient directly presents with shock. So you need to be very, very accurate in your diagnosis and manage appropriately. Vaccines, especially those containing adsorbents and soluble agents, latex and blood products can lead to anaphylaxis. So let us look at the pathophysiology of anaphylaxis. Anaphylaxis is a immediate type 1 hypersensitivity reaction. There can be exposure to foods and allergens, exposure to drugs, or physical stimuli like exercise, heat, cold, and sunlight. Foods and allergens, it can be either immunologic mechanisms or non-immunologic mechanisms. Within the immunologic mechanisms, there is IgE dependent mechanism and IgE independent mechanism. In IgE dependent mechanism, initial exposure leads to sensitization but doesn't cause anaphylaxis. Re-exposure leads to activation of the cascade. In non-immunologic type, non-IgE dependent type, there is indirect complement activation, generation of anaphylatoxins C3A, C4A, and C5A, inappropriate mast cell degranulation. The non-immunologic type is produced by physical stimuli like exercise, heat, cold, and sunlight. In the initial phase, release of free-formed mediators like histamine, which is a potent vasodilator, which is the cause for all the reactions like rashes, pruritus, itching at the initial shock. There will be lipid mediators like prostaglandins and leukotrienes, other mediators like platelet activating factor, tryptase, and interleukins, TNF alpha. In the late phase, release of inflammatory mediators, there can be cytokines and chemokines. All these will lead to vasodilatation, increased vascular permeability, airway smooth muscle contraction, increased mucus secretion, inflammatory cell accumulation, and autonomic system activation. The autonomic system activation is the one which leads to your increased heart rate and increased respiratory rate. We have already seen the signs and symptoms of anaphylaxis. Let's focus once more system wise. So what happens in the respiratory system? The first and foremost sign is sudden onset of breathlessness. Okay, patient can develop wheezing very rapidly. 45 to 50% of patients will present with wheezing. Pharyngeal or laryngeal edema in approximately 50 to 60% of patients. 30 to 35% of patients will have rhinitis. Symptoms pertaining to cardiovascular system: hypotension in 30 to 35%. 4 to 5% of patients, especially those in shock, can present with chest pain. Skin, urticaria and angioedema, 60 to 90% of patients. Flushing in 45 to 55% of patients. Pruritus only in 2 to 5% of patients. Gastrointestinal symptoms include nausea, emesis, cramps or diarrhea in 25 to 30% of patients. Neurologic symptoms include headache in 5 to 8% and seizures, especially because of hypotension and reduced cerebral blood flow, 1 to 2% of patients. So next is, once a patient presents to you, you cannot directly label him as anaphylaxis and treat only for anaphylaxis. You need to look for other causes also. That is called the differential diagnosis. Most common mimickers of anaphylaxis include vasovagal reactions. Sometimes there can be myocardial ischemia, arrhythmias, severe acute asthma, seizure, epiglottitis, hereditary angioedema, foreign body airway obstruction, Cassinoid syndrome, mastocytosis, vocal cord dysfunction, and non-IgE mediated drug reactions can also present similar to anaphylaxis. We need to look for all these causes, especially the vasovagal reactions where you don't need to give any treatment. Investigations doesn't help much in the diagnosis or management of anaphylaxis. Serum histamine levels, which are experimental, can be elevated after 5 to 30 minutes of reaction. Serum tryptase levels are elevated for several hours. These tests have sensitivity, but they are not specific, usually not elevated at the time of ED presentation. So, strictly speaking, no laboratory test will be useful in either diagnosing or management of anaphylaxis. So once we have some laboratory investigations, we need to focus on the algorithm for anaphylaxis management. You diagnosed an anaphylactic reaction, you secured airway, maintained the breathing, circulation, disability, and exposure. You have given epinephrine. Look for acute onset of illness, life-threatening airway and breathing problems or circulatory problems, and usually skin changes which clinch the diagnosis of anaphylaxis. Once you are diagnosed anaphylaxis, if a senior is not available, call senior for help. Lie the patient flat, raise the patient's legs to increase his BP. Adrenaline or epinephrine is the drug of choice. When skills and equipment are available, establish airway, high flow oxygen, IV fluid challenge, chlorpheniramine and hydrocortisone, which are second line of management, can be given. You need to monitor the patient very closely with pulse oximetry, ECG, and blood pressure. So when you identify life-threatening problems, I'm going to present some of the life-threatening problems here. Airway swelling, hoarseness and stridor. Breathing problems, there will be rapid breathing, there will be wheezing because of the bronchospasm, and there can be fatigue, cyanosis, reduced FiO2 and confusion. Circulation, the symptoms are because of the shock, pale, clammy, low blood pressure, fainted, drowsy and coma. You need to give adrenaline. We'll discuss about the dosage of adrenaline in the coming slides. And then second line of management include antihistamines like chlorpheniramine, which is symptomatic management, and corticosteroids to reduce the inflammation. When the patient is having shock, you need to give IV fluids. So first line therapy, as we discussed, epinephrine, oxygen, and IV fluids are the first line of therapy. Epinephrine in an adult patient, 0.3 to 0.5 milligrams IM, 1:1000 dilution. 0.3 to 0.5 ml can be given, or epifen 0.3 milligram dose can be given. In a pediatric patient, the IM dose is 0.01 milligrams per kg of 1:1000 dilution, or EpiPen Junior, which contains 0.15 milligrams of epinephrine. Avoid giving IV epinephrine in pediatric age groups. If IM route there is no response in adults, you can go for IV route. If you are expertise for managing any reactions that can happen because of epinephrine, 100 micrograms over 5 to 10 minutes, mix 0.1 milligrams in 10 ml NS and infuse over 5 to 10 minutes. IV infusion, start at 1 microgram per minute, mix 1 milligram, that is 1 ml of 1:1000 dilution in 500 ml NS and infuse at a rate of 0.5 ml per minute. Titrate the dose as needed. Pediatrics, IV infusion of 0.1 to 0.3 micrograms per kg per minute. Titrate dose as needed. Maximum of 1 micrograms per kg per minute can be given. Ask them to titrate the saturation more than 90, preferably 94% of saturation in both adults and pediatrics. IV fluids, as I told earlier, crystalloids are the fluids of choice. There is no role for colloids. Crystalloids in adults, 1 to 2 liters of bolus can be given depending on the condition of the patient. In pediatrics, 10 to 20 ml per kg bolus can be given. Second line therapy includes H1 and H2 blockers combined along with corticosteroids. H1 blockers, antihistamines, diphenhydramine or chlorpheniramine is the drug of choice. Diphenhydramine 25 to 50 milligrams every 6 hours, IV, IM or per oral. Pediatric dose of 1 milligram per kg every 6 hourly, IV, IM or per oral can be given. H2 blockers, earlier along with chlorpheniramine or diphenhydramine used to give ranitidine, but recently there is a ban on ranitidine. So if available, you can go with cimetidine, 300 milligrams IV in adults and 4 to 8 milligrams per kg IV in pediatric patients. Corticosteroids, usually hydrocortisone is the most commonly used drug in an emergency. 250 to 500 milligrams IV can be given. In pediatrics, 5 to 10 milligrams per kg IV, maximum of 500 milligrams can be given. The next steroid that is available is methylprednisolone. 80 to 125 milligrams IV can be given in adults, 1 to 2 milligrams per kg IV, maximum of 125 milligrams in pediatrics. Prednisolone usually given once the IV bolus has been given as a maintenance therapy of corticosteroids, 40 to 60 milligrams per day per oral, divided twice a day or daily. In pediatrics, 1 to 2 milligrams per day per oral, divided twice a day or daily can be given. One most important aspect you need to know is how are you going to treat the bronchospasm in patients with anaphylaxis. You can use nebulized drugs like albuterol or ipratropium bromide. Albuterol adult dose, single treatment of 2.5 to 5 milligrams nebulized, 0.5 to 1 ml of 0.4% solution. In pediatrics, a single nebulization of 1.25 to 2.5 milligrams as 0.25 to 0.5 ml of 0.5% solution can be given. Or if you don't have a nebulizer machine, you can go with metered dose inhaler, 4 to 6 puffs in both pediatrics and adults. Both the drugs can be repeated every 20 minutes as needed until the bronchospasm is relieved completely. Continuous nebulization of 5 to 10 milligrams of albuterol can be given. In pediatrics, 3 to 5 milligrams is the dose. Ipratropium bromide is usually given as single treatment, 250 to 500 micrograms nebulized. In adults, half the dose, that is 125 to 250 micrograms nebulized in pediatrics. Or if you are using a metered dose inhaler, 4 to 6 puffs with a holding chamber can be given, both repeated every 20 minutes as needed. Another drug for treating bronchospasm is magnesium sulfate. It's a smooth muscle relaxant commonly used in 2 grams IV over 20 minutes can be given. 25 to 50 milligrams per kg in pediatrics over 20 minutes. Treatment of patients on beta blockers poses a challenge in treating anaphylaxis cases because if you give epinephrine, which is a non-selective and alpha and beta receptor antagonist, it can lead to uncontrolled action of alpha receptors, will lead to severe hypertension. In these cases, glucagon is the drug of choice. Glucagon can also be given to those patients unresponsive to conventional therapy with epinephrine. The dose of glucagon is 1 milligram IV every 5 minutes until hypotension resolves, followed by 5 to 15 micrograms per minute infusion. Pediatric dose is 50 micrograms per kg IV every 5 minutes. Disposition and follow-up, which is very, very important in the emergency room. There are certain indications for ICU admission. Patients with anaphylaxis refractory to treatment, continuation therapy can be given in ICU. Patients who needed airway intervention initially and are put on mechanical ventilator should be on mechanical ventilator at least for 24 to 48 hours. So they need to be admitted to the intensive care unit. Patients who received epinephrine can be admitted to ED observation ward who doesn't require any airway management or stable after adrenaline dose. Patients who didn't require adrenaline and are stable at the time of presentation could be managed with fluids and antihistamines, can be discharged home. There are some other indications for admission like patients who are on beta blockers, patients who reside far from medical facilities because there is a chance of secondary action, patients who live alone, and significant comorbidities like asthma, COPD, and IHD, which can be complicated by anaphylaxis. And also elderly patients whose vitals are unstable need to be admitted to a hospital ward. So coming back to the current patient had a severe reaction and needed airway intervention to start with, and this patient should be admitted to the ICU. Follow-up advice usually contains antihistamines and short course of corticosteroids. Patients having frequent allergic reactions should be prescribed EpiPen and given instructions on appropriate usage of EpiPen. Thank you. If you have any doubts or any clarifications, any corrections, please post it in the inbox, and don't forget to subscribe and share so that it reaches wide audience. Thank you.